Thank you, Rainer, for this very nice introduction. I would like to take you to the art of deresuscitation, and basically I would like to give an answer to three questions. Why should we do it? How should we do it? And when should we do it? I have to disclose I'm a member of the Medical Advisory Board of Pulsionary Medical Systems. And yes, everybody probably lies now and then. So I will give a brief introduction, talk a little bit on the risks of fluids, results of meta-analysis, what is the pathophysiology of fluid overload, and then share with you a three-hit model of shock. This is the why, and then we will go to the when and wrap things up with some practical approach on how to do it. Biggest bias, everyone knows, is being the co-founder of this illustrious society, which is the World Society in Abdominal Compartment Syndrome. I'm very pleased that Professor Jan de Waal from Ghent, also Belgium, is our current president, and he will host a meeting in 2015. So what are we talking about here? We've heard in Azriel Priel's talk about goal-directed therapy, and this is really a hot topic. There are even journals dedicated to this. There are meetings dedicated to this topic. But what is the goal? I think the goal is to obtain a fast recovery for our patients from a shock state. But then what is the definition of a shock state or a state of shock? The US definition says that it is a systolic blood pressure below 90 millimeters of mercury after fluid resuscitation. I'm not sure whether this is a good definition to use at the bedside. I think the European definition states that shock is a mismatch between oxygen delivery and oxygen consumption. If we look at the surviving sepsis campaign guidelines, as Azriel alluded to this morning, I think it's a great step forward, but something is missing here. And the thing that is missing, I believe, is cardiac output. Cardiac output is the main driver of oxygen delivery. So I believe by definition, if you want to treat a shock patient, and you want to optimize DO2, you should measure cardiac output. So how then must we implement these surviving sepsis guidelines at the bedside? Well, you probably would not fly a plane without an altitude meter. A man thinks about sex on average once per hour. And yeah, you may ask yourself, where is this guy heading to? But let me try to make my point. A man looks at the speedometer of his car about once a minute. But would you ever seriously let your wife drive your car without a speedometer? Well, you probably would not do so. But would you treat a sepsis patient without a cardiac output monitor? And I think many of us in the room still do, and as Dr. Stockman nicely pointed out, we have guidelines and models of care, but no one is adhering to them. So I think that cardiac output is our friend. And as we know, some friends come with benefits. And now I'm trying to make my point. These are some modern monitoring devices. You see the EV1000 and the Pico device. And beyond cardiac output, these devices offer other parameters like global and diastolic volume, extravascular lung water, and SCVO2. So whenever we are confronted with a therapeutic dilemma or a conflict, which is a situation where each of the possible therapeutic decisions carries some possible harm, we must always support the organ that carries the highest danger for killing our patients. And for the purpose of my talk, I will focus on saving the lungs and avoiding fluid overload. We know, and we've heard this morning, that any measurement in the ICU stands or falls with its accuracy, but no measurement per se has ever improved survival, only a good protocol can do. But a treatment algorithm should follow physiology, or it may fail to improve outcome. Let's show an example of a strange protocol where volume versus pressure-limited hemodynamic management has been performed in septic shock patient. At the discretion of the attending physician, a fluid challenge could be performed if extravascular lung water was below 10. If it was above 10, then global and diastolic volume should be below 850. But we know from the Maitland study that it's probably not a good idea to give the patient fluid challenges until the patient is no longer fluid responsive. And in this study, in African children, mortality was higher if fluid boluses were given, regardless whether it's saline or albumin. We looked at normal values at baseline in patients with septic shock and surgical patients for global endostolic volume, and we found these values much less than the 850 that was used in the protocol. Brings me to the ebb and the flow phase of shock, and this is nothing new, has been alluded to in the past century, where the ebb phase was the phase where the patient had a thready pulse and cold clammy extremities. And the flow phase was the phase when the patient warms up in the OR and increases cardiac output. In these two phases of shock, we should have different targets and different goals. Initially, we should guide resuscitation based on functional hemodynamic parameters, maybe passive leg raising. But at a later stage, fluid balance and fluid overload and the impact on end organ function may even be more important. So extravascular lung water can by no means be a safe trigger for fluids, but should be a safety limit for stopping fluids, not for starting fluids. And that's the 4 questions that I want an answer for in my critical patient. When do I start giving fluids? Because the best fluid is probably the one that has not been given. At some point, we must stop, and maybe some patients need help with unloading and deresuscitation. So it's all about the benefits of fluid administration, the risks, and the benefits of unloading and the risks. The risks of fluid giving are there. They are fluid overload. And there's a lot of data. This is a retrospective study in septic patients where you see that survivors, and the message is always the same, survivors have a fluid balance on a daily basis which is less than non-survivors. If you look at the SOAP study investigators, a cumulative fluid balance was an independent predictor for poor outcome. The SAFE study has been alluded to, where it has been shown that patients with severe sepsis had a more favorable outcome, although not clinically significant, but in the subgroup of septic shock patients, maybe limiting fluid intake, there was a benefit for albumin, and this has been shown in subgroup analysis later on that the adjusted odds ratio was significant in favor of the use of albumin. In our own study, looking at incidence of abdominal hypertension, we found the same thing. Survivors have a less positive fluid balance than non-survivors. The FACT trial comparing 2 fluid treatment strategies in patients with acute lung injury, a conservative and a liberal. The liberal group had about 7 liters positive after 1 week. Although this did not result in a difference in outcome, there was significant improvement in lung function. Recently, the Finaki study in about 300 patients has been published, and it's the same. Patients with fluid overload have a poorer survival, and if you look at the amount of fluid accumulation, there is a linear relation to ICU mortality. The renal investigators from Australia also looked at fluid balances, and you can see again in non-survivors after the first week also higher daily fluid balances. So fluid accumulation may be related to end organ dysfunction. Here in patients with fluid overload, survival is less, and the investigators from the PICAR study group analyzed the relation between fluid overload, hemodilution, and a lowering in serum creatinine, making that this delays the diagnosis of acute kidney injury. So if you have a late diagnosis of acute injury due to dilution of serum creatinine parameters, these patients have much higher fluid balances. Can we do something about it? And this is a dramatic case study by Jean-Louis Vincent, where they removed 33 liters of anasarca within 52 hours in this patient. Murphy, albeit retrospective, nicely demonstrated not only that survivors have a less positive daily and cumulative fluid balance, but when he separated his patients into 4 groups, those who were initially adequately resuscitated and later on received conservative fluid treatment, and conservative being 2 consecutive negative fluid balances within the first week of ICU stay. So these patients carried the best prognosis. So what about fluid balance in sepsis? And this is a study that Jean-Louis Vincent presented. If this is a fluid balance +3, -3, you can see that if you look at survivors, more the fluid balance goes to the negative side than non-survivors, as is shown here on a daily basis. By day 4, survivors have a 0 to negative fluid balance. So probably we should avoid fluid overload. And this holds true whether you try to mobilize the fluids with diuretics, spontaneous diuresis, or renal replacement therapy. Survivors have a 0 to negative fluid balance from day 4. So what does the literature say? If we try to find an answer whether fluid overload is deleterious, and if we try to do something about it, will this improve outcome? So we pulled the data of different studies, and we see that non-survivors, after the first week, have a positive cumulative fluid balance about 7 liters. So can we do something about it? Well, if you would do a restrictive treatment versus liberal, you can see that in the restrictive group, you're able to avoid a positive cumulative fluid balance with about 5 liters. And showing in the first plot here, this had a significant effect on outcome, restrictive versus liberal fluid strategy. So I think the key message 1 is that why should we do deresuscitation? Because fluid overload is an independent predictor of poor outcome. So what about the pathophysiology? If the patient is underfilled, there is a convective problem and oxygen can't get to the tissue, but if it's overloaded, you have a diffusion problem and interstitial edema leading to end organ dysfunction and failure. We know that capillary leak may occur within minutes, and capillary leak may occur at a distance. This is a hamster cheek pouch in an animal where we induce a chemical peritonitis. So you look at the cheek, you induce the peritonitis, and you see the capillaries leaking at a distance. And that's probably why Stewart says that saline sucks, because you can literally drown patients with excessive amounts of saline. So I sincerely do hope that when I'm old and get into the ICU, I will not end up with a bag of saline, but we should avoid futile over-resuscitation. And it was one of the reasons also together, and this is the faculty of the first IFAD meeting, and of course, what do? You drink, and in Belgium, this is rather beer than wine. Giving too much fluids will lead to edema, and my bias comes here, may lead to increased abdominal pressure, mesenteric vein compression, and diminished venous return. Some of my colleagues will state that peripheral edema is only of cosmetic concern, but sure, the clinical point is that the patient looks a little bit swollen, and this may be scary for the relatives, but this is not a cosmetic issue. If the patient is swollen at the outside, it will be swollen at the inside, and a swollen organ will stop for functioning properly. Dilip Lobu alluded to this morning, that if you have given more crystalloids, you will have an increased gut to wet to dry ratio, and this will result in a diminished contractility. So whenever there is an injury, there will be inflammation and increased permeability, and this may lead to second and third space fluids accumulation. If we leave these fluids on board, there may be ongoing inflammation and increased permeability with third space and second space fluids, and I would call these toxic lymph, toxic ascites, and toxic peripheral and interstitial edema. Toxic because these will enhance ongoing inflammation and cause distant organ dysfunction, and this is what we refer to as multiple organ dysfunction syndrome. So the gut has been the forgotten organ, although the concept of capillary leak is widely recognized in the lungs and the kidneys. The same pathophysiological process occurs in the gut, but this concept is much slower to sleep through. The gut is the motor of multiple organ failure, and abdominal compartment syndrome could be considered as the ARDS of the gut, and that's why we alluded to this as AIDS being acute intestinal distress syndrome, but it got a lot of confusion, and afterwards I was invited to give lectures at HIV congresses. So we define this as acute gastrointestinal injury. Let me show you the 3-hit model of shock. Whenever there's a first hit, regardless whether it's burns, pancreatitis, or sepsis, the patient is intravascularly underfilled, and this is what's referred to as the ebb phase of shock. Fluids at this stage can be life-saving, and the treatment should be early goal-directed. Fluid balance may and must be positive. Ebb phase can be dangerous if the patient is underfilled. Then comes the second IT, properly related to ischemia and reperfusion and distant organ dysfunction. The accumulation of fluids should be seen as a biomarker of critical illness, and fluid strategies should get conservative with the fluid balance in equilibrium. And then two things can happen. Either the antibiotic is given or perfect, or you have a good surgeon with excellent source control, and the patient will resolve from shock and enter the flow phase and mobilize all the excessive fluids and edema. But many patients in the ICU may remain in an unresolved state of shock, entering a third hit, which I would call a global increased permeability syndrome, leading to edema in the lungs, the kidneys, the gut, and even the brain. If we keep on giving fluids at this stage, fluids may become toxic to the patient, and at this stage we should try to remove the fluids. So within this evolution of first, second, third hit, the monitoring may change from functional hemodynamics and then to organ function, and finally maybe to perfusion with ICG-PDR. Fluids from life-saving can be toxic and can kill the patient, and the goals change from early adequate goal-directed to late conservative fluid management to late goal-directed fluid removal, and that's what we call deresuscitation, with fluid balance from positive to negative. There's a slide from Jean-Louis Vincent. In the initial stage, we will give fluid challenges, but at the later stage, we must perform a reverse fluid challenge, which is maybe with the means of hypertonic solutions and removing the fluids. Jean-Louis Vincent refers to the SOSD, which is initial stage, the salvage treatment, the optimization, organ rescue, the stabilization, organ support, and de-escalation, which is organ recovery. And if we look at the different phases between salvage, you increase the volume, you stabilize during the optimization period, and then during the de-escalation or the deresuscitation, you should get your fluid balance back to normal. So the key message too is we should start to deresuscitate when there is a positive cumulative fluid balance with the presence of new onset organ failure. So when should we start to deresuscitate? Can we use the CVP? Well, it's probably not a good marker to use. Can we use other parameters for capillary leak, like the urine albumin creatinine ratio, like we use in burn patients? Not sure. We could monitor body weight or cumulative fluid balance, but not so easy for the nurses. Osmolality, oncotic pressure, so there are some things out there, maybe bioelectrical impedance analysis. But what about the ratio between the CRP, infection, inflammation, over serum albumin? And we found that this ratio is highest at day 3 and is increased in non-survivors. Capillary leak index above 60 was an independent predictor for not achieving a conservative late fluid management. So if you're leaking, you're rather keeping your fluids on board. Not going into detail, but bioelectrical impedance analysis may be able to demonstrate where the patient is, and this is a patient in normal condition, healthy individual, who may then develop a sepsis, a shock, a capillary leak, so he gets overhydrated. Then this patient may be with decreased body cell mass due to malnutrition, and then we may de-resuscitate the patient, bringing him back, and then in the anabolic phase. So this, for the future, I think, may help to identify the patients who need some de-resuscitation. So when it comes to extravascular lung water measurement, I think it's about 500 mL. It's the size of a pint, and this is the amount which is present in normal lung tissue. So if you would add 200 or 300 mL to the existing 500 mL, this will lead the patient into overt pulmonary edema. The fluids in the lungs can only be drained via 3 ways: the hilus, transpleural, or transabdominally. Brings me to the Burj Al Jarab, because there is a tennis court on top. And if you look at the surface of a tennis court, it's about 88 square meters. So the lung is a fairly dry place, and it needs to be dry for proper gas exchange, for surfactant function, recruitment, and diffusion of gases. So if you would double the amount of lung water from 500 to 1,000, which correspond to an indexed extravascular lung water of around 14, this would kill your patient. So it would be the same as pouring out half a liter on a tennis court. Just think about that. The lung is a fairly dry place. So when we looked at epidemiologic data in patients on extravascular lung water, non-survivors have a sustained increased extravascular lung waters. But non-survivors have a trend to increase the extravascular lung water over time. If we define a non-responder as a patient having a responder as a patient having a drop in extravascular lung water, this carried a good prognosis. And as you can see here, responders have a cumulative fluid balance in balance, while non-responders, so those who increase extravascular lung water, have an increase in cumulative fluid balance. Responders had a better survivor and had a faster weaning. Patients who had defined as conservative late fluid management, having 2 negative consecutive fluid balances, also had a better survivor and a faster weaning. Just one more thing. Greg Martin showed that the use of albumin with furosemide is able to limit cumulative fluid balance and to improve oxygenation. So that's the reason why we thought that if you would combine a positive end-expiratory pressure to squeeze out the fluids out of the alveoli, by adding hyperoncotic albumin, we may attract some fluids from the interstitium, and by putting the furosemide, we may clear the water out of the lungs into the vessels out of the patient. And we studied this in 57 patients compared to historical controls. So the PAL group had higher PEEP levels. They had, of course, higher albumin because it was substituted. And this resulted in a drop in abdominal pressure, a better oxygenation, a drop in extravascular lung water, and this probably because the cumulative fluid balance was in balance. And this resulted better survival and faster weaning. If we put together early conservative and late conservative, this was the group for us with the best prognosis, but we did not have information on fluid balance in the ER and OR. I'm getting over my time, so let's conclude with the last key message is how should you do it? I think that extravascular lung water may be the key. Getting back to my 4 questions, when to start, when to stop, when to start unloading and when to stop, I think we need more information, and it's dynamic. Initially, we need hemodynamic parameters. Then we may look at organ function with extravascular lung water, and we must stop deresuscitation if there are issues with the microcirculation or with perfusion or increasing lactate. I believe that extravascular lung water may be the key to deresuscitate, and PAL treatment can be your PAL. So instead of going blindfold, we must be aware that the targets are moving between the first, second, third hit, but also the goals are moving. So a good study protocol should be early, aggressive, goal-directed within the first 8 hours. Then it should get to 0, and by day 1 or 2, we should go for deresuscitation. So it's about the right fluids, giving right, and using the right monitor in the right way. Having said that, I thank you for your kind attention.